Good morning. I'm Claire Stowers. I'm a second-year internal medicine resident at the University of South Florida, and today I'm going to be talking a little bit about point-of-care ultrasound and its applications in intravascular volume assessment, particularly taking a look at the VExUS protocol. So before I begin, I'd just like to say I have no disclosures and no conflicts of interest to declare on this topic. And so before we get started, just a quick definition of what we're talking about today. So VExUS is an acronym that stands for venous excess ultrasound, and this is a method that was developed. It's a scoring system using measurements taken from different vessels in order to assess the patient's venous congestion, and as a byproduct of that, their tissue perfusion, which is really a lesser emphasized concept within that spectrum of volume status. As you know, we classically think of forward flow and whether tissues are getting enough perfusion, enough blood flow delivered to them. We're often focused on mean arterial pressure, we're focused on cardiac output and preload to try to make sure that the tissues are getting enough blood flow, but this is providing us information about the other side, the post-capillary venous congestion and kind of the implications that that has on tissue perfusion. This was studied in the late 2010s and published in 2020 at the University of Montreal. They were looking at a cohort of cardiac surgical patients who were planned admissions to the ICU after their procedures, and this was studied most closely in tandem with AKI. They utilized different scoring systems, different cutoff points to try to validate which cutoff points would be the most predictive for end organ damage, and they settled on one which I'll go into later. And since its development, since its validation, it's been studied in CHF, and again most closely in tandem with AKI for its predictive properties on that. Now, when we think of volume status and point-of-care ultrasound, the thing that first comes to mind is the IVC assessment, which was actually my first introduction to point-of-care ultrasound. Even as a medical student, that was my task in the MICU, was to go and measure the IVCs of our critically ill patients to try to make a determination about their volume status for that day and help make decisions on rounds about what needed to be done. So just a brief overview of the way that this is performed. It's a longitudinal view of the inferior vena cava. It's taken from a subxiphoid approach, and you're looking at the cross-sectional diameter of that vessel. You're trying to look just distal to the hepatic vein entry into the inferior vena cava, and you're measuring that diameter, and you're also kind of looking to see, you can use M mode or just eyeball it, looking to see when the patient inspires if there is that respirophasic change or that inspiratory collapse that indicates that the patient is euvolemic and not volume overloaded. So this is the kind of scoring system that we use in general. If the IVC is a smaller diameter with good collapsibility, greater than 50%, we can infer that the right atrial pressure and the central venous pressure is low. And then as the IVC increases in diameter and becomes less collapsible, meaning no respirophasic changes and kind of plethoric, we can infer that the CVP and the right atrial pressure is really high. And this is, of course, most useful at its extremes to make inferences about the patient's quote-unquote volume status and determine kind of the next clinical step there. But as we know, this is really an imperfect system for several reasons. One of those being one of the most common situations that we use this in is in the critically ill patient in the ICU setting, and many of these patients are intubated. You know, we use this because they can't tell us about their symptoms, they can't complain of shortness of breath, they may have anasarca all over their body that limits the evaluation on physical exam for peripheral edema and JVD and things, but intubated patients have kind of this pressure artifact from the positive pressure ventilation that might affect those measurements, affect the collapsibility of that. Additionally, any increases in your intra-abdominal pressure would compress the IVC, and that would be independent of any right atrial pressure that's present. So like a Valsalva maneuver could cause an inaccurate reading. And then other examples too, in chronic disease, so chronic pulmonary hypertension has been shown to, these patients have remodeling of the IVC that would affect kind of your baseline measurements and affect your inferences about their volume status. And as I stated before, this is most reliable at the extremes of its spectrum, so it really ends up being more of a qualitative than a quantitative assessment of the volume status. Another reason that this becomes important, this VExUS ultrasound, is that it provides a bit more detailed information about the actual perfusion pressure gradient that's at play. And so we typically think of MAP minus CVP as the perfusion pressure. That's actually not the most accurate way to think of it. That's kind of a bird's eye view. And so looking at this next slide here that demonstrates the pressure throughout the vascular system, you have high pressures, fluctuant pressures in the left ventricle, obviously with systole and diastole, and then moving out through the aorta to the arteries and arterioles, you lose a lot of that pulsatility, and then you lose a lot of that pressure as well, just as your cross-sectional area increases with all of the branching into very small arterioles. So when you get to the point of the capillaries, you actually have a capillary arteriolar pressure that's really in the 35 millimeters of mercury range. And so truly at the tissue level, the perfusion pressure gradient is the pre-capillary arteriolar pressure minus the post-capillary venular pressure. So as you can see, that creates a much smaller window of opportunity and a much smaller margin of error for any increase in the post-capillary venular pressure, because it's not going to be long before that starts to overcome that very moderate pre-capillary arteriolar pressure, and you could easily get changes in flow in the incorrect direction based on venous congestion. And this is another illustration just kind of demonstrating that duality of the system, where you can get tissue injury both from a low flow state as well as from a congested state. Just kind of highlighting again that importance that both sides of the system be working properly. So from a low cardiac output and low perfusion pressure, you can get tissue damage. And here's demonstrated the liver, the kidney, and then showing just as similarly with elevated central venous pressures and venous congestion, you can get similar but different maybe types of tissue damage, but at the end of the day, just as dangerous for end organ results for patients. And so how do we really assess this on a more precise level? One of the ways it's actually been around since the 90s is portal vein flow. So the portal vein has a predictable waveform, and it's been shown to change in a predictable way with venous congestion increases. And this has been demonstrated in decompensated congestive heart failure, left ventricular dysfunction, and it's been correlated with AKI. There's a paper that they even showed that with successful diuresis in the setting of decompensated CHF, they were able to monitor and track the changes in the portal vein waveform from normal on the left to abnormal on the right, being in a state of decompensation. And then as they successfully diuresed these patients, they were able to correlate the change back to the baseline portal vein flow with the return to baseline serum creatinine. So it's a pretty reliable marker that really flows in parallel with the changes in creatinine that we commonly use to kind of assess where the patient is at on the curve there. And so this really kind of creates an opportunity to take what we know from the past, from IVC assessment, from portal vein assessment, and create a more multifactorial approach to get a little bit more precise about what these volume status changes are causing at the tissue level, and get a closer assessment of what's actually happening in the venous side of things. And so this is where VExUS really kind of was born from. As I mentioned, it's VExUS ultrasound. It's a multi-vessel approach, and it takes a look at the IVC, the hepatic vein, the portal vein, and then the intrarenal veins. And this is scored and graded in a matrix that was developed in 2020 from a grade of 0 to 3. And so 0 would be normal findings, no evidence of venous congestion, and 3 would be severe venous congestion. And this really strongly correlates with the risk for end organ damage, most notably AKI. And so here's kind of an overview of what the waveforms look like as we progress from a normal waveform to some mild changes suggesting venous congestion, and then as venous congestion becomes more severe, we can get these predictable, more severe abnormalities. And so I'm going to take this one by one. This right here is your hepatic vein waveform using Doppler on the ultrasound. So normally you have this kind of waveform that almost resembles the CVP waveform that we're familiar with. So you have an upward deflection, the A wave that occurs during atrial contraction when the right atrial pressure exceeds the mean systemic filling pressure. And then you get your S wave, which is occurring during systole. So at this time, the venous blood is entering the right atrium. It's transiently enlarged by that tricuspid motion towards the apex. It's similar to the X descent of the CVP waveform. And then you get your D wave that occurs during diastole. This is venous blood continuing to enter the right atrium, now as a passive chamber. You can think of the Y descent of the CVP waveform. And then you can see this waveform pattern start to change with changes in venous pressure. So as the right atrial pressure increases, the S wave becomes diminished and then ultimately reversed. You can see this kind of flipping above the baseline from the mild to the severe abnormalities. So what's happening here is the right atrial pressure is exceeding that venous pressure that prohibits its return or causes reversal of that flow during the systole, and then all of that blood must return during diastole, causing that kind of emphasized D wave as we get more severe changes. Similarly, kind of looking through the stages of mild to severe, we have the portal vein. So under normal circumstances, it has a very calm, it has a very undulating flow. It's very far separated from the central venous pressure because of those extensive hepatic sinusoids that it's kind of passing through before it makes its way back into the central flow. And typically this flow is hepatopedal, meaning towards the liver, returning that blood from the splanchnic organs. However, as the right atrial pressure and the central venous pressure increase, that atrial contraction becomes more and more transmitted through the hepatic sinusoids. It ends up causing an intermittent flow reversal away from that hepatopedal pattern, and you start to get a more sinusoidal wave pattern as seen in the kind of mild abnormality frame in the middle. Eventually, the flow can become biphasic, meaning above and below the baseline, as that pulsatility becomes more intermittent. And so that's the hallmark of a more severe venous congestion. And then last, taking a look at these intrarenal venous waveforms, it's important to note that these measurements are taken on the small interlobar or arcuate venules. This is not the renal vein. It's too closely approximated to the renal artery, and it's difficult to get good measurements from that spot. And so even these small vessels, you do get both arterial and venous waveforms. So above the baseline in this green frame is your arterial waveform, but we're going to be focused on below the baseline at this venous waveform. And similarly to the portal vein, it exhibits a kind of undulating, very calm flow without real demonstrable waveform pattern. But with venous congestion, it starts to become biphasic, very similar to that portal vein. And in the presence of severe congestion, it actually starts to display those S and D waves, similar to those that we talked about in the hepatic waveform. So again, as the pressure increases, the S wave is diminished, and then it's ultimately reversed above the baseline, so it disappears, and then you get a very similar waveform below the baseline that kind of approximates that of the hepatic vein pattern that we see. And so going into the grading system, as I mentioned before, grade 0 is a normal classification. It's no evidence of venous congestion, and really once you take your IVC measurement and you see that it's less than 2 centimeters in diameter, you can say that this patient falls under grade 0, and there's really no need for additional waveform testing. Once you have a dilated IVC beyond 2 centimeters, you start to take these other venous measurements to determine what grade they fall under. So grade 1 is mild congestion. It's the combination of an IVC greater than 2 centimeters and any combination of normal or mild changes in any of these waveforms. Grade 2 is moderate congestion. This is an IVC greater than 2 centimeters and at least one severely abnormal pattern in any of those 3 vessels. And then moving to grade 3, you could have severe congestion. This is an IVC greater than 2 centimeters and 2 or more severely abnormal waveforms in the hepatic, portal, or intrarenal veins. This grading system is discussed in the 2020 paper. They arrived on this one with their statistical measurements kind of being the most predictive of AKI. They had some other cutoffs that they were looking into, and I'll go into that data here on this next slide, but this system was the most statistically significant. This VExUS C here highlighted in yellow, and it's showing you that grades 2 and 3 are significantly associated with the development for AKI. So you can see those hazard ratios of 2.65 and 3.65 respectively, which were the only categories under these different scoring matrices that had a statistically significant hazard ratio and predictive value. And so this is some data from that paper as well, just kind of looking at the positive likelihood ratio. And you can see that this VExUS scoring system, which is the one I've outlined here, shows a positive likelihood ratio of 6.37. This is important because this is greater than any positive likelihood ratio generated from looking at any of these metrics in isolation. So this is the portal Doppler only, hepatic vein Doppler only, renal Doppler only, and then even looking at CVP measurements on their own. This combination score, looking at all of this information, has a greater positive likelihood ratio than even the CVP measurement as measured from a Swan-Ganz catheter. And that's really kind of important because that's an invasive procedure. It introduces the risk for infection. It can be very uncomfortable for patients, and this method using VExUS and point-of-care ultrasound actually has greater positive likelihood ratio than that very specific measurement. And so this really gives us a much more precise approach and a less invasive approach to kind of make these decisions about the venous congestion and what needs to happen with the patient's volume. So mentioning again the clinical inferences we can make from this information, grades 2 and 3 significantly associated with the development for AKI with those hazard ratios of 2.6 and 3.6. Scores showing a grade 3 level of congestion are greater predictive value for AKI than looking at any of those metrics in isolation. So really, it's greater than the sum of its parts, this protocol. And another thing that was interesting is that the grade 3 classification was also positively associated with other physical and biomarkers that we commonly use for congestion. They took a look at the NT-proBNP it was correlated with. It was correlated with rises in CVP, and it was also correlated with the patient's cumulative fluid balance, which are all kind of things that we traditionally rely on to make these kind of assessments. One issue that this does have is that it has a low sensitivity for AKI, which really is just a product of the fact that AKI is such a multifactorial condition, can be caused by a number of things aside from just problems with volume status. It can be intrarenal, it can be medication induced, it can be infection induced. Lots of different things can cause AKI. So this method is just looking at one of those. So naturally, it has a low sensitivity for predicting AKI. So what does this mean for our clinical management, and really where can we head with this new information? So we can perform VExUS when we're unsure if our patient is clinically volume overloaded. And this is, again, it's most useful at the positive end of the fluid balance spectrum. It's really not useful for telling you anything about if your patient is volume depleted, as this is looking for specifically the presence or absence of venous congestion in those different compartments. And so you can use this to determine if their fluid status is good, they can kind of maintain that, or whether they're volume overloaded and maybe need fluid removed. So this can inform your choice to continue or stop administration of fluids and volume resuscitation. I should note this has not been validated in sepsis, but maybe if you have a case of overdiuresis or something like that. You can determine the candidacy for fluid removal or diuresis, and you can assess the risk for end organ damage here most reliably, most studied in AKI. So VExUS grade 2 or 3, that would maybe point you in the direction to remove fluid in order to improve those tissue hemodynamics and the tissue perfusion in the splanchnic organs. And this is really a real-time clinical indicator of the volume status and the venous congestion. It's faster, it has a more temporal correlation to the biomarker than biomarkers like creatinine, as we know that can come with a delay, and it's been demonstrated to kind of move in tandem with that return to baseline. So this would be a really great way to monitor your patient's response to treatment without subjecting them to lab draws or invasive kind of other forms of monitoring like the Swan-Ganz catheter. And this can be reassessed and monitored throughout their clinical course to try to predict if they're heading for AKI, and also tracking their response to the interventions that you are making. Of course, like any clinical assessment, this comes with its own limitations. As I talked about earlier, the IVC has its own caveats that can affect its measurements and might affect kind of your scoring there using this matrix. And then the other vessels too are really prone to caveats as well. Some of them specifically, the portal vein can be affected by a thin habitus. You have greater transmission of those waveforms. Anything parenchymal liver disease like cirrhosis, portal hypertension, portal thrombus, or any type of AVM that may be present could affect your results, affect your measurements, and then it would cause misleading data and inaccurate scoring if you're just relying on that matrix without that prior knowledge. Hepatic vein Doppler can be affected by different things. One of the examples given was tricuspid regurgitation. And then also, this is kind of an advanced point-of-care ultrasound approach. If you're a POCUS novice, this might be time consuming or difficult to accurately obtain the views needed in order to get these waveforms. So that could be a limiting factor as well. And then this is relatively new. This was just published in 2020 and has been studied a few times in different populations since. So it's not extensively studied. It's not been studied in sepsis. Definitely more research is needed to really say that this is a robust method and a reliable method to use to make clinical decisions about the patient's volume status. But as I mentioned, this really does have a lot of advantages. This is fast, it's non-invasive, it gives you real-time, precise information about the patient's venous congestion and volume status. It's quantifiable data about the individual patient and their individual physiology to help make decisions and help predict clinical course. And it can be used for tracking and monitoring in response to these therapies that we're giving, whether it be giving more fluids or taking fluids away. It can kind of help keep you in check, help make sure you're keeping the patient on the right part of their volume curve. Thank you so much, everyone, for listening. I hope this was helpful to you. Sorry we couldn't get into more of the practical kind of information about the system and the acquisition of images, how those are obtained. There's a lot of valuable resources that I ran into, and I'll link them here at the end about if you're looking for more information about how to actually obtain these images and kind of start implementing this system into your clinical practice. Thank you so much again. Here are my references at the bottom. The video there is a YouTube review of this protocol and a lot of the data that went into it. I found that extremely helpful. I hope you enjoyed, and we'll see you next time.